Good morning. I'm Dr. Steve Chapta, and it's my distinct pleasure and honor to welcome Dr. Madhukar Trivedi to Semel Grand Rounds. Dr. Madhukar Trivedi is professor of psychiatry, chief of division of mood disorders, and founding director of the Center for Depression Research and Clinical Care at UT Southwestern Medical Center, where he holds the Betty Ho Hay Distinguished Chair in Mental Health and the Julie K. Hirsch Chair for Depression Research and Clinical Care. Dr. Trivedi focuses on developing and validating biosignatures of depression. He also conducts research on pharmacological, psychosocial, and non-pharmacological treatments for depression. And if that's not enough, there's more. Dr. Trivedi is also an outstanding psychiatrist who is arguably the world leader in stimulant medication research. That's how I've come to know Dr. Trivedi. He's the lead MPI for NIDA's Big Southwest node of the CTN, and I've been working with Madhukar as co-MPI for several years now. Last year, Dr. Trivedi's team, the ADAPT-2 team, led the world in producing the largest randomized controlled trial on medications for methamphetamine use disorder. He showed the combination of extended release naltrexone plus high dose bupropion produces superior outcomes to placebo in reducing methamphetamine use, outcomes that are both statistically significant and clinically relevant. Today, however, Dr. Trivedi will present evidence from his work in developing biosignatures for depression. As PI for the STAR-D trial, Dr. Trivedi's research in depression treatments changed practice in the US. That's something important about Dr. Trivedi and his research work. He conducts his work always thinking about how his findings will be scaled up and translated into everyday practice to reduce suffering, with developing evidence to advance precision medicine. So I want to welcome Dr. Trivedi to the Semel Grand Rounds. Today, you're talking about biosignatures for depression, advances in precision medicine.
Thanks so very much, Steve, for your kind introduction, and for all of you who know my work in depression. One word about Dr. Chapta. You know, all this work in addiction, I have learned a lot about it from Steve and from Walter Ling at UCLA. So he is a true partner in that endeavor. Today, I'm going to try to talk about the whole idea about biosignatures, biomarkers for depression. These are my disclosures. I work with pharmaceutical companies in the drug development phase. Often after the drug is approved, I do not end up working with them. I am not today going to talk about any of this, by the way. My current goal today is to really talk about how best to think about brain and blood-based biomarkers of antidepressant response, applying data-driven approaches to develop precision medicine for depression, and then assess the direction of where we are going. I think in some ways, 10, 15 years back, we all used to talk about biomarkers as a pursuit that we should all be engaged in, and we were still struggling with the validity and the stability of these biomarkers. I think the last 10 years have produced some fantastic findings, and I'll review some of those as I proceed. And now I think we are at the threshold of where we should be thinking about how best to utilize all this knowledge to take us to the next level where we can truly realize the benefit or the potential for precision medicine. And so that is really where I'll try to take our discussion towards the end. So I think that we have spent the first 30, 40 years really using serotonin monoaminergic reuptake blockers for depression. We had significant success, but really this field has stagnated for quite some time. And I think now it has become very clear that we have to be thinking about a translation approach, both in terms of drug development for novel antidepressants, but more importantly, for targeting so that we are, you know, our traditional antidepressants lead to 30% remission rates with any given antidepressant. Effect sizes are modest. Part of that is because we are throwing the same treatment to people with heterogeneous biomarkers or biological mechanisms associated with their disease. And so we now have to try to link basic mechanisms with psychopathology, create a framework to study these mechanisms and circuits that cut across traditional disorders, because it may be that we have to be mindful that, and we've known this for quite some time, antidepressants work for anxiety disorders. Patients with depression report significant anxiety, and in fact, some of the worst outcomes for depression are in those people who have significant anxiety, sleep difficulties, cognitive dysfunction. So we have to be thinking about the heterogeneity of this and understands mechanisms for that given patient or the group of patients. And then we have to try to really classify based on these mechanisms to understand mechanisms and most importantly, to target new treatments. And I think we have at least made some progress in the last 5 years with S-ketamine and ketamine coming out with the SAGE postpartum GABA modulator with for postpartum depression, and with transmagnetic stimulation. We are really at least broadening our targets for the treatment of depression. We have not yet really reached the point where we are being precise about who needs what kind of intervention. And that is really the work that we have to go forward with. Current research does show that the importance of screening these physiological markers based on imaging, neurophysiology, genomics. Unfortunately, genomics and epigenomics has not yet really provided the kinds of benefits we should be thinking about. Proteomics and metabolomics, in fact, may be farther along, and I'll show you some of this. But I think that this underlying biological factors that drive depression per se, but more importantly in a group of people, and can be used as objective markers so that we can measure the dysfunction at the beginning, match them with the right treatment, monitor their progress, and modify treatment if the progress is not actually happening. Just nomenclature-wise, people talk about biomarkers as if they are one thing. I think that we have to recognize there are diagnostic biomarkers. Well, these are going to be ultimately the holy grail, because that is where we will be able to look at somebody at the beginning of their journey so that they may not even have symptoms or may have minimal symptoms, so to speak, at risk or early prodrome, and identify those so that you can target really a management and interventions to prevent the onset or even worsening of the symptoms. I think that work is ongoing in many places. I'll show you some of our work, but I don't think we are far along with there. Where we are far along is with treatment-based markers and treatment response biomarkers, and I will show you that data. Ultimately, we want to develop predictive biomarkers that can be either mediators or moderators, and we really have to do much more work on that. The range of biomarkers that we should be thinking about in terms of measuring, right from genomics and transcriptomics to metabolomics, are wide, and how best to really, and obviously it's circuit-based and electrophysiological markers. And I think the next generation of work is going to be, and I'll show you some glimpses of what we are doing in terms of mixing these so that you have 2-3 domains of markers that can actually go on to define a phenotype. That is really going to be helpful. Some of the work that has already been done has shown promise primarily in reward circuit dysfunctions based on task-based fMRI, looking at probabilistic reward task, effort task, et cetera, that taps into reward expectancy, reward performance, et cetera. Emotion processing and regulation circuits with emotion conflict resolution with either fMRI or EEG are the kinds of markers that can again give us a sense of, in a given individual, what is the nature of their dysfunction so that we can then match them with the right treatment. So somebody who has reward circuit deficits may require a totally different treatment intervention than somebody whose primary the disorder is driven by negative emotion regulation. Inflammatory markers, metabolic markers, and gut microbiome markers are beginning to actually give us a very solid idea of the mechanisms associated with depression in many cases. One clarification for all of us to keep in mind as we go forward, I think there's been 30 years of work. You can accuse me of having been involved with that work also, as some people where we have looked at the left side of the panel. If you look at, these are prediction markers, so that at the beginning of the illness or the treatment, you measure several things, clinical as well as biological, and then identify what is associated with good outcome versus bad outcome. What that does is it tells you how bad or good the disorder is, rather than in a particular case, anything specific about it. In some ways, I like to say that if I had asked my grandmother about how best to treat depression, she would have said, if somebody starts having an illness early, has a lot of bad outcomes in the middle, has attempted suicide, has medical comorbidity, has not done well with treatments, they're unlikely to do well. That is what the left panel tells us. That's not tremendous. What we want is moderators, so that at the beginning of treatment, if we can identify, measure, which is what people in cardiology and in rheumatology do, based on the markers, you have to say treatment B, in this case, the red line, is the right treatment for this because their outcomes will be much better if you use treatment B based on the markers you have identified at baseline. So this moderator or marker or set of markers is what really we should be aiming to go to. As I mentioned earlier, genomics has not helped us. Pharmacogenetic predictors are primarily, in my humble opinion, dependent on pharmacokinetic and very little, and some with distribution. ABCB1 transporter SNPs have been associated with better outcome with some of the PGP substrate drugs, like sertraline over non-PGP substrate antidepressants. But that is the limited nature, the pharmacodynamic markers that we should be really trying to identify that help us precisely identify the right treatment have been slow to come along. FKBP5 has been seen, but even that seems to basically confer a general poor response rather than any specific marker. So, in general, the unfortunate fact, or the fortunate fact for all of us who are researchers, because that'll continue our research careers, is we have to be thinking about all the way from genes to symptoms through protein networks, cells, brain function and structure, as well as some disease phenotyping. So let me now launch into two main domains I'm going to talk about, the blood-based and brain-based markers. This is an example of a blood-based marker. A lot of people have talked about inflammation as associated with severe depression, as well as suicidal ideation and behavior. We have been doing a lot of work on really this particular cohort in terms of adolescents who have already attempted suicide. And as you all know, even with the best of treatment centers in the country, we have one at Children's here, Columbia has, UCLA has, a lot of centers have fantastic step down as well as aggressive treatments for these adolescent teens. And yet, humbling fact, 25% of these kids will attempt again, even with the best of treatments. So our real goal should be to figure out who those 25% are. So this is an early study that actually went into us getting a grant, and I'll talk about the grant in a minute. But here we looked at 3 groups of patients, kids who had attempted suicide, 10 to 25-year-olds, 37 of them. Then we have a group cohort, like a Framingham cohort for depression, which includes a third of the patients, kids who are at risk. So they have family history of depression, bipolar disorder, suicide, or alcohol use. And these we call them at risk, and we are monitoring them. So the idea behind that is to really tease out what real risk is. And then a group of healthy controls. And when we looked at IL-4 in this population, you can see the clear dose response. That is, those kids who had attempted suicide, they have the lowest IL-4 compared to those at risk, and much normal in the healthy control group. So this is from a simple bioplex human chemokine 40-plex assay, and we were able to identify this IL-4 as a key marker in that population. Obviously, our next study is going to actually look at cells associated with Th1, Th2, et cetera. So there are several other candidate markers. IL-17 has been really looked at. If you look at IL-17 in mice exhibiting learned helplessness, you can see a clear effect on Th17 cells. By the way, IL-17 is made in Th17 cells, which is primarily, largely seen within the gut. So therefore, any elevation of IL-17 could be seen as obviously some effect on the gut membrane permeability and IL-17 getting into bloodstream through the gut. There are animal models that show inhibiting IL-17 can mitigate Th17 infusion-dependent learned helplessness. And if you transfuse animals with Th17 cells, it does promote learned helplessness. So there is a basis for this. We looked at this in a sample where we had people who were given an SSRI alone or had additional bupropion or venlafaxine and mirtazapine. But the main exciting finding is with the comparison between the blue and the red lines, where if you got SSRI alone and your IL-17 was elevated, then as you can see, the outcomes are not actually profoundly good. Whereas if the IL-17 was elevated and people got bupropion, then their outcomes are actually quite good, suggesting that patients with elevated IL-17 may need something that affects the inflammation process. There is an old paper from Paul Greengard's group at Rockefeller where they looked at several of these antidepressants and found that bupropion and mirtazapine, amongst all the others, including SSRIs, SNRIs, tricyclics, those two had anti-inflammatory effect. So we obviously have to now try to understand this mechanism better, but clearly suggests that if there is ample evidence showing that if there is inflammation, traditional SSRIs have poorer response compared to those people who do not have inflammation. So this actually matches with that earlier finding. In fact, there is a study often cited, but we have to be modest about what it means, but published in JAMA Psych by Andy Miller from Emory, where they looked at treatment-resistant depression patients and gave them infliximab versus, which is an TNF-alpha antagonist, versus placebo in a group of treatment-resistant depression patients, and did not find any effect. But then when they looked at the subsample of TRD patients who also had elevated CRP, those patients who had significant elevation of CRP were the ones where they were able to separate infliximab from placebo in treatment-resistant depression patients. So there's reason to believe that traditional antidepressants may not be ideal, that there may be other things needed, and bupropion in this case is a good example. We then expanded to look at additional measures of inflammation. So we then looked at PDGF, platelet-derived growth factor, and this cartoon tells you that if there is elevated PDGF, then there is a disruption in the blood-brain barrier, which allows infiltration of peripheral immune cells. This could lead to CNS inflammation, may affect the dopamine circuit, and there again, bupropion may be a positive effect, and you can, lo and behold, see this in the same sample that we looked at, where bupropion has preferentially better outcome when you look at that sample versus those who got SSRI monotherapy. And the most interesting thing about this study was that this effect that I just showed you is primarily driven by anhedonia. So those people who were on bupropion and had anhedonia had the biggest effect in terms of positive effect for antidepressant response. So I'll come back to inflammation in a minute, but in line with this Th17, we also have been interested in looking at gut microbiome. There is ample written about the gut-brain axis, and there is some suggestion that we may have to be thinking about host immune system and its interaction with gut microbiota, its impact on neuroinflammation, and whether or not these are drug treatment targets through either immunomodulatory agents that can be used so that the gut microbiome host immune system interaction can be modified, or can we give dietary supplements through probiotics, prebiotics. There is actually data in irritable bowel syndrome, for example, that fecal transplant from healthy animals to animals with IBD model can reverse symptoms. And in fact, there's some human data associated with that too. Nobody has tried this in depression, but it is an intriguing idea that if you can modify gut microbiome, that you could improve the gut immune brain axis. We looked at this in a sample in that we have, by the way, just a pause and the sort of explanation. I have launched a study called TRAD, Texas Resilience Against Depression. Steve will be excited, intrigued, because everything is big here. So TRAD is Texas Resilience Against Depression. But the idea behind that is it's like a Framingham study where we currently have about 1,500 people enrolled. And the first cohort is now reaching a 7-year mark. We bring them in twice a year and do deep phenotyping, gut microbiome, blood-based markers, genetics, epigenetics, RNA, seek white blood cells and various other things, proteomics, et cetera. And in that sample, we looked at this 205 TRAD population patients, and we found 3 clusters, as you can see in the brown boxes. The left one is the one that is then associated, if you look at it on the right side, with significant levels of anxiety, irritability, and depression. This gives us an idea that this, and what we find here is that if the microbe density is decreased, then that is associated with higher levels of anxiety, irritability, and depression. We now will be doing much more careful evaluation of the types of microbes, taxa that really drives this, and then see how we can modify it either by diet or other things. So looking at inflammation again, there is, as I mentioned, there is ample evidence for this, so I don't need to belabor this, but one intriguing finding repeatedly has been seen is high CRP levels are associated with greater risk of hospitalization and suicide. In fact, from the GenDep study looked at the CRP levels, and you can see kind of a dose response where as the CRP levels increase, the response to the SSRI is lower than the response to nortriptyline. So if you look at low levels of CRP, there doesn't seem to be a difference between the GenDep study was a comparison of nortriptyline versus escitalopram. And as you move up to the right, to the right where the CRP levels increase, there comes a 3 or more is a cutoff where you can immediately see that the efficacy for nortriptyline is much better than the efficacy for escitalopram. This is a small sample, but still an interesting level of finding. We replicated this in the same data set I showed you earlier, where we looked at CRP in patients who were given an SSRI and those who also had a bupropion on board, and you can see the same difference. And in fact, if you look at it, if you had, so this is where we should be going in the future, that if this was a randomized control trial looking at comparison of SSRI versus bupropion plus SSRI, the basic premise there was that if you start people on a combination, can you actually increase efficacy? And what we found was it doesn't matter. It doesn't lead to better efficacy if you just look at the general population. What we could have done, but that was premature at that time, but now we want to do, and that is randomize people based on their CRP levels. And if we had done that, so as you can see, overall remission rate in that population was 31%, 30.9. But if the patients who had less than 1 CRP had gotten the SSRI, remission rate would have been 57%. And if the CRP was more than 1, which is the blue bar on the right side, and they got bupropion, their remission rate would have been 51%. And so if we had predetermined the treatment selection based on CRP levels, our remission rate for the same sample, for the same 2 treatments would have been 53%. And I think this is the kind of precision approach that we need to do as we go forward. And to be very transparent, I am not aware currently of a treatment study that has purposely specifically done this, with some exceptions. The FAST-MAS study from NIMH that looked at a kappa antagonist and in people with anhedonia and looked at their circuit-based biomarkers. But even there, they found the effect of the kappa antagonist on circuit-based markers for patients with anhedonia, but the effect on anhedonia was very modest. So therefore, the idea is they were able to change the circuit, but not the symptoms. Same thing happened in a study from James Morrow's group with NCQ1, where they also ran into the same thing. You find the biological effect, but not the clinical effect. So more work needs to be done. I think that the furthering of this idea of what to do with suicidal kids really led us to start. We have seen the rates of suicide increasing, and we have no idea what the reason is, but that is clear indication that starting at 2007, suicide rates in the US for teens especially is going up. So we know there is inflammation. There have been studies with immune dysfunction and depression and increased pro-inflammatory markers found in patients with depression who have high suicide ideation. So we developed this conceptual model to study these suicidal teens. And we are now currently evaluating all these components, their aberrant immune cells, autoimmunity, and to figure out what is their immune dysregulation, the definition, the precision of their immune dysfunction needs to be clarified. Just saying somebody has inflammation doesn't obviously help us. And we are also going to look at stress, family history, early life trauma, comorbid disorder, suicide attempt related trauma. I have really the sense, we'll see, my thinking is that we will get strong signals for some markers, but the biggest signal is going to be by developing an index. And you could then have like a cardiovascular tracker or a dashboard where you fill in the metrics for each of these markers, and that will help you decide what is the likelihood of a reattempt. So we are engaged in this large 225 participant study, 12 to 18-year-olds with recent history of suicide. And we're going to use healthy adolescents as controls. This is the basic study where we will really look at immune characterization as well as clinical characterization. And the immune characterization is quite deep and extensive. We're going to look at RNA, plasma, Buffy coat, serum, PBMC, and CBC, et cetera. So first, sort of very pilot work that we did initially with a small sample I'm going to show you, but by looking at mass cytometry, we're going to compare to other platforms. This allows us to interrogate multiple cells at the same time. It aids in discovery, and the biggest thing is it quantifies cell counts so that it allows us to figure out what is the cell density in any given sample. We looked at a small sample of kids who had attempted suicide and compared them to healthy controls. And what you can see here is with this CyTOF study, we were able to identify two distinct clusters, cluster 5 and cluster 7. The cluster 5 is basically classical monocytes, and cluster 7 is gamma delta T cells. When you look at the density of these cells and those who had attempted suicide versus healthy controls, you can see that cluster 5 is increased and cluster 7 is decreased in, or more said it differently, cluster 5 is reduced in, so the gamma delta T cells are increased in, is decreased, sorry, let me back up. The gamma delta T cells in suicidal patients are increased compared to healthy controls, and the classical monocytes are reduced. So we now are going to actually challenge these cells to see if we can specify the exact mechanism of how that leads to other changes in the patient's cells. looking at brain-based markers has been an exercise for the last 30 years. I'll give you some of this data. I think more work needs to be done. There's clear benefit for looking at connectivity in brain regions through EEG. Here we looked at early changes in Theta-Band connectivity in the EMBARC study. A lot of these biomarkers I described are coming from the EMBARC study I led for several years, and now a lot of these data published in the literature. Here we looked at early change. So we did EEG and then did the EEG again at week 1 after starting them either on sertraline or placebo. And we looked at this change in connectivity between two areas, the rostral anterior cingulate and anterior insula. And that in 1 week change, that can actually tell you whether or not a patient is going to be a remitter or a non-remitter. So this is now moving from moderator to this early mediator analysis where the first week EEG connectivity change is significant enough. And if you, for example, you could imagine a world where this change is not seen and you would label them as potential non-remitters and stop that treatment and start somebody on a different treatment. So this is almost like a stress test for the patient. We've looked at the same sample in many different components of brain function. So this is looking at cerebral brain, blood flow with ASL. And here what we found is very fascinating. This pattern that is described here is the pattern that you see in remitters. And so what we found is if the patients were lucky enough to have been assigned. So remember, this was a sertraline versus placebo study with no preconceived selection. Everybody got either sertraline or placebo in a very random fashion. We then post hoc did their brain circuit change, ASL data, and if we then mapped them back so that if we found that if a patient had the pattern we just identified, and they were lucky enough to have been randomized to sertraline, then their remission rate is almost double the remission rate of same group of patients who were given sertraline, but did not have the signature of ASL that we saw earlier. And the reverse happens for placebo. Again, telling us that if we use this pattern at the baseline and decide whether they should get sertraline or placebo, if we had been lucky enough to had the prescience to know this in advance, our remission rates overall would have been double just by virtue of doing that one test. We see the same in this functional connectivity, where higher connectivity is associated with better outcome in these regions on the top left panel, and lower connectivity in the other regions shows the same preferential benefit for sertraline and the reverse on the placebo side. But there again, you can see that the real driver is hyperconnectivity between regions. There are some default mode network and somatomotor network, as well as dorsal anterior network, attention network, and the limbic node. What is most interesting is this also showed here. This also showed the same pattern. If this dysfunction was actually predefined, identified, and the patients were lucky enough to get sertraline, their remission rates were much better than if they did not have the dysfunction. Finally, we looked at EEG biosignature, and here what we did was actually look at the same large sample of 309 patients, sertraline versus placebo, 2 months, and we developed an AI algorithm that predicts treatment outcome. And what we did, this was published in Nature Biotech a couple of years back, where the algorithm really uses convex optimization to minimize prediction error. So it does spatial filtering, band power feature extraction, and linear regression that allows us to identify the AI-driven pattern for treatment outcome. And you can see on the left lower panel, sertraline-trained cortical spatial signatures in both right parietal occipital regions and the left prefrontal and parietal occipital regions. That is the pattern associated with best outcome for sertraline. And we used that on a trained set and then applied it to the test sample. And there is a clearly linear relationship showing that you can predictably apply this algorithm on a new test sample. And wonderfully, this same algorithm, this same signature, does not actually predict anything if they are given placebo. So it is precise for sertraline. In fact, the paper which showed data, I didn't put it in the slide, that the same, that the algorithm, I mean, the signature for those people who are likely to do better with TMS is distinct from the sertraline signature. And so therefore, you can imagine there can be several signatures that are very precise for any given treatment. So where do we go from here? I think one of the things I've been saying all along is where we really go to is twofold. One is any of these signatures that we've been identifying have to actually be able to use 2 or 3 domains together to precisely define the population and use that to a priori to develop a randomized control trial. And the second thing I'll show you in the next few slides, we have to be mindful that particular subsymptoms and associated symptoms and the RDoC domains, so to speak, really have to be also determined if we are going to get a very robust signature. So here we looked at the sample of the same EMBARC sample, but those who had suicidal ideation, and looked at their reward circuit function. And in that component of functional MRI, where we were looking for reward expectancy, you can clearly see that those, and we looked at 48 brain parcels that were associated with suicidal ideation. And if you look at the A panel, higher suicidal ideation was associated with increased brain function during reward expectancy in the inferior temporal, inferior frontal, and angular cortices that encompass basically the dorsal attention network, default mode network, and the executive control network. Whereas higher suicidal ideation on the right side was associated with weaker brain function during reward expectancy in superior, inferior, insula, posterior central, and precuneus. So 2 different areas for suicidal ideation during reward expectancy can be clearly seen. The other thing is we have now begun to look at anger and aggression. The human Connectome sample project, young adults, about 1,000 of them. We use the parcellations, as you can see on the right side, up on top, and you can see the distinction for hostile aggression and anger aggression. The hostile aggression is driven by functional connectivity between subregions of the striatum. And the anger aggression is driven by functional connectivity between regions of the default mode network. So you can immediately see the pattern of aggression has something to do with, but the biggest real thing to look at is the Habenular-Striatum functional connectivity and irritability. So here we segmented the habenula on the left side, you can see, and its connectivity to the rest of the brain. And you can see on the right side that the habenula and the striatum relationship on the left for females and on the right for males is very distinct. So there is a clear gender effect. And we all know about irritability, anger, et cetera, and its expression amongst men versus women. But now we have a brain signature associated with these distinctions. Finally, a couple of other things like this, looking at brain aging and what we looked at. I think the biggest thing is people have begun to see that there is accelerated brain aging in conditions, including diabetes, depression, et cetera. But as you can see, the right panel, very interesting because for patients A1, for example, or B1, you see, if you look at their sertraline, the higher baseline, so that those patients who had accelerated aging at baseline, they had higher levels of impulsivity and suicide propensity. and those with the highest levels of accelerated brain age had the least improvement in impulsivity and suicide propensity. So traditional antidepressants, if you give and there is already accelerated brain aging, you may have much less effect on these components of depression. Finally, the last data slide, and then I'll stop so we can open up for questions, is here we looked at the reward task functional MRI measurement for differential activation. These reward expectancy contrasts were obtained in about 121 regions of interest based on functional parcellation. And then we were trying, as I mentioned repeatedly, combining, right? So we looked at cytokines and chemokines on the Biorad 40-plex and in these 40 immune markers. And we were able to identify basically two clusters. Cluster 1 made up of 78 of the subjects, and cluster 2, 49 subjects. And if you see on the right side, the red and the blue basically represent the two clusters. And so they are almost mirror images, but cluster 1 is a group that has these same regions that has hyperconnectivity, and the same regions for cluster 2 shows hypoconnectivity. So if you were, for example, doing magnetic stimulation, you would use different parameters for these two subgroups. Currently, everybody coming in gets the same kind of stimulation. If we look at differences in irritability between the two clusters based on treatment arm, so this was really now based on treatment arm, you can see that the two clusters respond differently to both sertraline and placebo, albeit not profound effect size, but still different. And so therefore, remember, these are people who already have inflammation in their system. So sertraline is not likely to be profoundly effective, and yet you see some differences. And treatment by group, by time interaction is statistically at least significant. And this is for brain age studies, this is a little bit smaller. Same thing happens with suicidal ideation between these two clusters. So in summary, I think there is increasing evidence for biomarker use in depression. Subtyping needs to happen for combinations. If we just depend on one marker, it's not providing us a full picture, because somebody who has reward expectancy and hyperconnectivity through the Habenular-Striatum but has no inflammation may be different from somebody who has inflammation and some metabolomic changes or with gut microbiome. So for personalizing medicine, I think it is on the horizon. We are pretty close, but hopefully soon we'll talk about it. I'm going to stop here, Dr. Sharpta, and see if there are any questions.
Yeah, that's a great presentation, Madhukar. Thanks for this presentation. Please enter your questions into the question and answer box, not the chat box, but the question and answer box, please. There's a question from the floor. Since the typical team diet is highly pro-inflammatory, has anyone looked at the impact of switching to a whole food, plant-based diet on the level of suicidality when inflammatory markers are elevated?
Short answer is there has been some work on looking at minor diet modifications, probiotics, et cetera, but this is actually the key. The question is fantastic, by the way. Not really, we don't have enough data. We are beginning to ourselves develop studies on this with one caveat, trying to map, and you know, Steve, we do this in timeline follow back for drug use, right? Trying to map the exact consumption of what somebody has done over a week is much harder than it looks. And so we are trying with some success, but I think there is some noise in their ability to record everything they take on a regular basis. But it is an intriguing question, and I think that is the right question to do. We are beginning to design these studies, so thanks.
There's another question in the chat, but I want to follow on to this question. Can you talk a little bit about, I know enough about the microbiome to be dangerous. So one of the things I've learned in looking at microbiome and methamphetamine in the gut is that the microbiome doesn't change quickly And once established, it tends to go back to the set point. So what are your thoughts about, that? And then the corollary to that about just kind of, can you talk a little bit about behavior microbiome link? Like how likely is it that microbiome is actually affecting behavior in some way?
Affected by behavior or it affecting behavior?
Exactly. Yeah, exactly.
So I think that you're absolutely right. There is a two-way street. But before your first part of the question, I think you're absolutely right that, but that is true for a number of these homeostatic aspects of human behavior. So I do exercise research also, as you know. Exercise is, again, the same thing. Most people end up returning to their general normal level of exercise on a regular basis, unless they consciously make a decision to change, and that happens for a few days. So you're absolutely right about same thing about gut microbiome. With gut microbiome, where people have succeeded in making changes is where they've given externally things like probiotics. So that is overloading the system enough that that can sustain itself. The kind of question earlier that came, that moving away from animal or processed foods to pure vegetarian, plant-based diet may lead to it, but you're absolutely right there. To sustain that is often a little problem. So how stable? I think you can change it. Whether you can keep it stable will require significant behavior change. On the other hand, some similar things happen for weight control, right? Same thing for exercise. So I think that can be done, but it's going to be hard. The behavior part is very intriguing. There are data in animal models, at least, where changes in their gut microbiome can easily be reflected in their levels of anxiety. That is seen. So whether increase in anxiety then changes the gut microbiome is still unclear. But there, animal experiments are easier to do. But there, if you do change gut microbiome, you can modulate the level of anxiety.
Great. A question from Jim McCracken, great talk. Are any markers ready for the clinic? What about C-reactive protein? And that sort of maps on a question I had. It's really impressive, the inflammatory link to behavior and the C-reactive protein with the SSRI monotherapy and the buprenorphine or the bupropion and SSRIs. Is that ready for the clinic?
So I think that the short answer, Steve, I've thought about this, I've talked about this many places. Here is the point. If this were cancer, if this were diabetes, if this were stroke, if this were toenail fungus, this would have led to change. It is a $5 to $10 test. Primary care physicians, where it should be the place, not in psychiatry, because by the time they have come to us, they have done so many treatments. But in primary care, where the physician is trying to make a decision between an SSRI or bupropion, sort of Pepsi versus Coke or whatever, at that point, if you have that luxury of doing CRP and there is some elevation and you avoid an SSRI and go to bupropion, I think that would be ideal. So short answer is, I think it is ready for prime time. It is low cost with high yield. I think there is a bias and stigma about our illnesses so that people take longer to make a change.
Right. What about the kind of along the same level? And I think you're probably going to answer me the same way. I was impressed with the irritability marker. What are your thoughts? Is that ready for bringing into the clinic to take a brief measure of irritability to help guide decision on treatment?
So I think that the measurement part of irritability, I think, is ready for prime time. We have actually thought about this very much for the last 5 years, and now have a rating instrument called CAST-IRR, which is a 10-item rating instrument for which we have established psychometric properties across many populations and published on it. If anybody is interested, I'm happy to share the rating instrument. I think that it really is very important because what we see, and some of that is unpublished, it's really, we are working on it, is that if your irritability persists and your depression gets better, but irritability persists, you are at a higher risk for suicidal ideation than if your irritability improves. And we've seen that not only in depression, but in suicidal kids and in addiction also.
Great. A comment from Walter. He's in the audience and he says, you did good. So
Good. Thank you, Walter. As I mentioned at the beginning, Walter has been an amazing mentor for our work, my work on stimulants. So thanks, Walter, for your partnership.
Great. Helen Lavretsky asks, speaking of lifestyle factors, would resilience training, stress reduction via mindfulness improve suicidality and provide coping skills to children?
I think that is, Helen, absolutely the most important thing. And in fact, now my center is working extensively on putting in resilience building prevention programs in high school. So we have a 5-session interactive program that we put in high schools to teach them. So it's an experience-based program where we take over the classroom, they get this 5-session where they learn about mental health, about help seeking, about resilience building, about how to help somebody, how to help themselves, etc. And we published the first, so we've done 20,000 students, but 3,000 of them provided consent, and we published the results in Journal of Clinical Psychiatry just early this year, clearly showing that just this thing in a classroom, not identified patients, but everybody, reduced depression, anxiety, and suicidal ideation overall. So clearly something is happening now. As Helen is pointing out, we may need to now do mechanism studies, and even getting consent to do questionnaires was a yeoman's work, but we are pursuing this, and absolutely important, Helena, and I think that's a key question. Can we reduce stress responsivity that would then decrease the risk for the onset or worsening of a new episode?
Great, thanks. Nancy Lee asks, are there any salient biomarkers for former chronic stimulant misusers, those who use meth, experiencing major depressive disorder that affect medication choice?
I think that short answer is not enough in the literature. We just completed the ADAPT and inflammation marker analysis, not yet ready for prime time, but I think we are seeing some signals, and in the next couple of months, we'll actually have full analysis done. So there seem to be signals that suggest differential outcome for the combination of naltrexone plus bupropion in methamphetamine users.
It's an interesting point you raise, and I've heard similar comments about that combination pharmacotherapy since that trial's been done, and there are important affective changes that happen as a result of both naltrexone and bupropion. So I think that's a great thought. We have a request for sharing the irritability scale, so I'm guessing that you'll make that available to us and we can send that out here.
Yes, I will send it out to you, Steve, and you can, as long as you're using it for academic purposes, you can use it anytime. If you're using it for commercial purposes, you'll have to go through UT Southwestern.
Great. One of the questions that comes up from looking at this kind of work is that you have translational work. The work is translational. You're trying to get it into the clinic, but you also require to do the work expertise at multiple levels across several compartments and include behavioral phenotyping. So where do you see this kind of work being done best? And is it the future for the field of depression?
You mean to say besides my group?
Besides your center.
I think that is a very nice question, and I'll tell you, I sit on the promotions tenure committee at UT Southwestern, and a lot of you are on your own promotion tenure committees, and PNT committees currently have a hard time figuring out how to do this, because this is really becoming clearly and truly team science. If I get imaging, I have to tell you, be fully transparent. My colleague, Sharice Senfat, who is my mentee, but used to be now a colleague, she is in charge of analyzing. So she goes through and makes sure that the habenula can be segmented. So she took a 3-month course and did the segmentation on habenula. And I had the question, but she did the analysis and hard work. So we have to work as a team. So there is imaging expertise in my group, but there is EEG expertise, there's a gut microbiome. We just have a fantastic colleagues, Dr. Jane Foster, who is a PhD neuroscientist, has her own lab in the center. She is my go-to for gut microbiome. So she tells me what to do. So we have real true partnership collaboration if we are going to do this. So short answer to that question is, I think that we have to be thinking about building a team, and this is real true team science.
For the early stage investigators who might be listening today, would you, I mean, when you bring these sort of multidisciplinary protocols into study section, how do they fare? Would you encourage someone who's an early stage investigator to think multidisciplinary and to think about this translational work, or should they first establish an area of expertise and then branch out? What are your thoughts?
I think what I have seen success with, and unfortunately, NIH is not known to really go out on a limb and fund real innovation, right? So what I have seen is what succeeds, like with Charisse, my colleague who does imaging, I really focused her time, she focused her time initially on getting publications from one domain, which is imaging. Like she published in the American Journal of Psychiatry, the first functional connectivity paper on EMBARC. And she has followed that up with a lot so that she is now a functional imaging person. Now her next R21 she just submitted included inflammation. So that is how you first do something which gives you credence in your one domain. May not be all nature and science papers, but still establishes your name. Then you bring in the other people in the team. And probably would be helpful to connect with a senior mentor. Like if you're doing something at UCLA and you work with, with Steve or Andy Luchter, then you have the collaboration in place and then you can build it.
Great. Well, thank you, Madhukar. We're at the end of the Q's and A's. I will say I have multiple remarks here noting how great your talk is, how erudite, well presented, and cutting edge. Thanks very much. And I'm certain that people can get a hold of you if they have other questions or want to pursue a research question with you. With that, I'll say thanks.
Thank you, guys.